Good evening, everyone. We are so excited that you have joined us this evening for another webinar put together by our external affairs team. I'm Dr. Edith Bradshaw-Sanchez. I am a primary care pediatrician here at Columbia, and we're really so excited to talk tonight with our wonderful panelists, who I'm going to introduce in a second, about what for us as primary care pediatricians and parents is sometimes a really tricky topic to navigate, and that's food allergies and food sensitivities. While we give everyone a second to join and get situated, I want to tell you about a couple of exciting things happening here at Columbia Children's Health. If my slides advance, I promise they were just advancing a second ago. Here we go. So we have the 10th annual specialty updates for the general pediatrician coming up December 2nd and 3rd. It is a 2-day virtual CME course for pediatricians, NPs, and family medicine providers. I have either gone live while it was happening over the past few years since I've been at Columbia, or watched it after, which is an added benefit of having a virtual meeting. It is truly incredible, and it is the 10th annual, and there's so many exciting things that are going to be discussed. You can register now. We're going to put the link in our chat, or you can just scan this QR code. And just a quick reminder, we also this year put a podcast series out. It is called The Stuff That Matters for Kids' Health. I host it, and I had the pleasure of talking to some really smart people around our medical center about a number of things that we think are really helpful for parents. So if you can take a listen and help us spread the word, would be really helpful, would be really grateful as well. We are also on social media at Kids at Columbia. And with that, it is 6:02. I know people will be joining in the next few minutes, but I do want to go ahead and introduce our wonderful panelists this evening. So we have first here on my slide, Dr. Jackie Jossen, who is a pediatric gastroenterologist here at Columbia. She's also the director of the Celiac Disease Center, and will be telling us a lot more about celiac this evening. We also have Dr. Joel Brooks, who is a pediatric allergist here at Columbia, as well as Sally Dorfzaun, who is a pediatric dietitian, and she is specializing also in IBD. So with that, let's get started. Let me stop sharing my screen. And we'd really, give me just one second. We really wanted to start this evening talking a little bit about how we make diagnoses of food allergies versus food sensitivities. So starting with both you, Jackie, and Joel, just to dive right in, food reactions, right? Reactions, I'm calling them reactions for now, are very common. Not all of them, of course, end up being a true food allergy. So my first question for both of you is, at a high level, right, just starting this out, how do you differentiate between a food allergy and a sensitivity when a child has had a reaction? Maybe we can go to you first, Joel.
Sure. Hi, everyone. So that's a great question. And the number one thing that I use, not testing, not anything, number one thing is the most basic, the patient history. The history of the reaction, the symptoms that the patient had is absolutely key here. And that tells me the difference between a food allergy, a food-induced allergic procticulitis, a food-induced enterocolitis syndrome type picture. It's all in the history. For example, a food allergy will usually present with hives, swelling, coughing, wheezing, shortness of breath, nausea, vomiting, diarrhea, dizziness, fainting, lethargy, all immediately or shortly after ingestion of an offending agent, a food. So it's very fast, it's immediate. That's kind of one of its hallmarks, is the speed of which the reaction occurs. Other conditions such as FPIES, or food-induced enterocolitis syndrome. So this condition presents with delayed onset. So 2-3 hours after ingestion, there's projectile vomiting, and dehydration is a very common, and lethargy are very common effects from such severe nausea, vomiting, and diarrhea. But again, that's delayed. So there's, the immediate reaction with food allergy, but then you have this 2-3-4 hour delay with FPIES, this food protein induced enterocolitis syndrome. And in contrast, the condition sometimes termed milk protein allergy, but as allergists, we actually like to use the term food FPIAP, which is food protein induced allergic proctocolitis, typically seen in infancy. And this is early onset infants, sometimes as early as 1 week old, but 2-3 months old. These are patients that come in with blood in their stool. And that's due to a dietary protein, sometimes from mom, that's even transmitted in breast milk. Very small amounts are enough to trigger it. But again, the presentation is so different. It's this blood in the stool, very irritable children. And so the history tells me this. And that's what I need most of all, is kind of hearing, what is the story? What are the symptoms that happen? Immediate, delayed onset, and what the actual symptoms are. That's how I begin to distinguish between what kind of reactions and what's going on.
Yeah, great. Jackie, for you, how do you think about it? And I'm sure there's a lot of overlaps.
Yeah, there's a lot of overlap, but I agree with Joel. I think, the number one thing is to look at history. Depending on the symptoms of what's going on, will point you in a direction of true kind of gastrointestinal pathology versus kind of a food sensitivity. So, if a patient is, losing weight or waking up in the middle of the night, having multiple episodes of diarrhea, that's a very different story from someone who, gets some tummy grumbling after they eat pizza Fridays at lunch. So the history tells a lot. I think the one thing in GI when we start looking at some of these conditions is, we do need some laboratory tests to kind of help us filter through some of these initial reactions. So celiac is one, for example, where, we really need the test to help us make the diagnosis. So patients will come in and they think that their symptoms, if they have celiac disease, should be directly related to when they ingest gluten, which is not true at all. So gluten induces the small intestinal damage, but then anything they eat can cause a problem if you have intestinal damage and are malabsorbing. So it actually has nothing to do with the direct ingestion of gluten time-wise, as opposed to like what Joel would probably tell you with a wheat allergy, where you would have a reaction right after eating a wheat product. So that's a little bit of difference between wheat and gluten and how celiac works. Once you rule out some of those underlying processes like celiac disease, the next way I go looking at it with history is food, diets, like diaries. And the symptom and food diary, and I'm sure Sally can elaborate on this, is a very complicated thing. Number one, it's hard to get patients to do it, but it's so helpful when they do. And one of the things I would tell pediatricians is, if you're sending a patient who you think may have some kind of reactions to food or is having diarrhea or belly aches, did I freeze here? Oh, sorry, I'm not sure if I froze there for a second. So if the patients are having diarrhea or belly aches, it's always helpful for them to come with a food and symptom diary, but it needs to be more than just sandwich. That's not going to help me. It can't be cereal. It needs to be cereal with whole milk. It needs to be salad with Caesar dressing, including, everything that was in the salad. So people will come in and they'll say, oh, I ate chicken and I was fine, but then I ate chicken and I was not fine. But one is chicken parm and one is plain grilled chicken, not the same thing. So they need to be very granular in their details. But if they do that, that can be a tremendous help, especially when it comes to irritable bowel syndrome and being able to review that diet.
Yeah, that's really helpful. And honestly, sometimes I'll refer to you guys as a primary care pediatrician, and I do recommend that parents keep a food diary as they're waiting for their appointment with you. And so having that level of detail is helpful in my counseling as a primary care pediatrician. Now, my other question for you both is, how do you, and what tools do you have? Because sometimes the diagnosis isn't clear despite our best history taking. And sometimes you do need to do testing. You do need to do things like elimination diets. And so I wonder if you can talk a little bit about when those things are appropriate to do. And I'll start with you, Joel. And who should be doing them. And I think that's helpful both for the primary care pediatricians who sometimes feel like they want to help, advance the diagnosis, but also for parents as they're setting expectations of their primary care pediatrician and the allergist. So what are the additional tools and when is it appropriate to use them, Joel?
Sure. So there is allergy testing that's available. The two most common forms that people think of when they think allergy testing are blood testing, what we call immunocapillary immunoRAS testing, which tests for IgE, an antibody that's made against a particular food. For example, peanut IgE or hazelnut IgE or egg IgE. And then there is skin testing, what we call skin prick testing, where we take extracts of the allergen and actually put it on the skin itself. And we wait a short period of time and we look for a small hive that develops at the site where the extract is placed. So no needles are involved. Traditionally, it's a relatively gentle test, shouldn't hurt too much, can get a little itchy for kids who do go through it. But the catch with that is the negative predictive value of allergy testing, both skin and blood testing, is very good. It's well into the 90 percentile. So about, let's say 95%, depending on the food in question, when it's negative. The issue is what happens when that test is positive. And unfortunately, the positive predictive value of the test without a clear history of reaction. So for example, a peanut reaction where someone ate a peanut, developed hives, swelling, and began to vomit. Without that clear history, the positive predictive value of a peanut test is about ranging between 33 and 50%, which means it's about as accurate as flipping a coin to tell me if a patient is allergic without that history. So allergy testing really should only be done in select situations based on the history, based on the concerns, and should never be done kind of as a general panel test, for example, but only as targeted towards the concerning food. And so when I have a patient that comes in with a concern for a specific food, they'll usually wind up getting tested for that food and potentially any food that might cross-react with that food. But I don't usually recommend testing before they come into the office, because ultimately what I do will be dependent on their history and not necessarily based on any prior testing that was done. And the last thing I ever want, especially when dealing with infants and young children, is for them to have gotten tested beforehand and either remove a food from their diet that they were already eating just because it was a positive test, because the clinical significance of a positive test when someone's already eating that food is next to nothing. If someone's able to, from an allergy perspective, if someone's able to eat a food, it's never worthwhile to do an allergy test against that food because a positive test is just a false positive. And it happens so often for us. But also testing even before there's been exposure, especially in infants, it's very dangerous because what we know about food allergy, one of the few things we truly know is that delayed introduction increases the risk for developing a food allergy. And having a positive test is only going to make parents more hesitant to introduce foods. And we really want them to start introducing the allergenic foods around 6 months of age, as soon as their child is really able to start tolerating solid foods. Obviously, we want them to do it safely and avoid any choking hazards, but we really want them to be exposed, and testing too early when there's been no reaction, no exposure, really just only causes more anxiety for families, more delay in introduction. So we really try to avoid that aspect. Yeah. As far as elimination diets go, I really try being as specific as possible to the food in question or the concerning food. So I very rarely will recommend elimination diets without a clear history of a reaction to a food. The one scenario where I will do that is in the case of the food protein-induced allergic proctocolitis. So in infants where, let's say 1 month old presenting with irritability with feeding and blood in their stool, I will recommend families try elimination of milk, for example. Milk and soy are the two most common food triggers for this condition, with milk being by far the more common one. So I'll try to do one food at a time and try to be as careful about it as possible, because again, avoidance of a food is going to increase the risk for developing a food allergy. Likewise, I don't ever recommend avoidance of food when it comes to atopic dermatitis or eczema, because we can treat the eczema, but if we let a food allergy develop, it becomes much more difficult. It's very difficult to treat and outgrow a food allergy depending on the food in question. So based on current studies, we do not recommend avoidance of a food because of eczema. So with the exception of the proctocolitis scenario and a specific food triggering an allergic reaction, whether food allergy or FPIES, the food protein-induced enterocolitis syndrome, very rarely will I recommend elimination diets initially.
Yeah, that's all really helpful. And I think you touched on a couple of things that we all wonder about. We have a couple of questions in the chat about it. In terms of the age at which you can do skin testing, what is the youngest that you can do it?
In theory, it can be done at any age. In practice, I don't like doing it unless ideally, again, there's been a reaction. And so most kids will begin early introduction of foods by around 5 to 6 months of age. And if we have a reaction at that point in time, then already I can do the skin testing and likewise blood testing. But unless there's been a reaction, for example, a 2 or 3 month old who's never been exposed or really hasn't had a history consistent of a true allergic reaction, I won't do the testing for it. And kind of piggybacking off of that, certain conditions like the proctocolitis or FPIES, for example, there is no actual testing for it. It's purely a clinical diagnosis. So the allergy testing, when we think of allergy testing, the IgE testing or the skin testing is really specifically targeting towards that immediate dangerous food allergy scenario, which again, most kids will begin introducing those foods at about 5 to 6 months of age. So that's when we'll typically do that.
Yeah, perfect. And I think you also touched on something that I think is really important. I mean, everything you just said is very important and very helpful. I think, with the relatively new recommendations to introduce allergens early in order to reduce the risk of developing a food allergy in the future, there are many parents who want to get testing first. And from what you're telling us, not only is it not helpful in terms of making a potential diagnosis, but then it leads to delays, right? Which ultimately cause harm. So that's really, really helpful. We have a couple more questions about this that just came in through the chat. How long after a food elimination do you consider it a sufficient trial if there's no change in symptoms?
In terms of the proctocolitis, so for the elimination for the proctocolitis, I'll usually give it, it's not immediate. You do have to give it some time. So I give it at least 2 weeks. Sometimes I need up to 4 weeks to see complete clearance of typically the blood. Irritability tends to go away a little bit earlier, but that blood in the stool can remain for several weeks. And so I always warn families that they can, that just because they've eliminated it does not mean that it's, that they're going to see an immediate change in symptoms. Food allergies, you see very quick results with treatment, with removal. Reactions do not last long, but when it comes to proctocolitis, this is much more of a delayed process. We don't fully understand the mechanism, but what we do know is that it can take up to weeks. And that goes for, the elimination from the food from mom's diet as well, if she is breastfeeding.
Yeah. Joel, you mentioned this, but just to make it super clear, and then I want to move on to you, Jackie. In terms of, because the current recommendation is in children who do have severe eczema to do some peanut allergy testing and non-allergy testing, right? We've sort of gotten this guidance over the past few years as general pediatricians. And so is your and your team's approach that it's really not helpful, even in infants with severe eczema, to do any sort of testing before introduction, just to make it super clear?
Exactly. It's truly, unfortunately, it is unhelpful. the recommendations were very good. Were very good, had very good intentions. With the idea of eczema does put kids at a much higher risk for developing food allergies. But what we started seeing is that these kids are getting tested, then we have these positive results, and ultimately, even in the high risk scenarios, one study showed 53% of patients in the high risk, so not just the general population, but these kids with severe eczema, 53% of them will have a positive test, and yet there is no clinical significance to that test. And so unfortunately, the false positive rate is so high that ultimately, for those scenarios where you have such severe eczema in already 4 and 5 months old, I recommend starting as early as possible. Give the egg, give the peanut at that 5-month mark in a way that's tolerable and safe for the patient to ingest. Because again, we want to be mindful of any choking hazard, but we want them to be exposed already at that point in time, because otherwise they are going to be at a much higher risk for developing food allergies.
Yeah, all very, very helpful. Jackie, going back to you, I wonder if there are additional tools that you use in GI to sort of help you differentiate these things and tell them apart.
Yeah, so I think with GI, it's a little bit different because the people who land in my office are going to have slightly different symptoms, and sometimes it's non-specific, belly pain or diarrhea, and there's a lot of overlap between those symptoms in the setting of food sensitivity and in, for instance, if someone has a mild case of Crohn's disease or celiac disease. So we do often need some of these initial blood tests. To be fair, the pediatricians are great, and the kids often come with exactly the blood work I already need, and it's done. But in most patients who come with some non-specific GI symptoms and they haven't been able to find a pattern, because again, history is really important. If they come and they tell me, well, every time I avoid dairy, I'm fine, I don't need a test to tell you this is lactose intolerance. But oftentimes we do need some basic lab evaluation to just reassure ourselves that there's nothing else going on. If all of that is, well, I should say this, if the celiac numbers, because I have to make my plug for celiac here. So just like we see a lot of false positives, like Joel was talking about, we see with the TTG-IgA, which is the best screening test for celiac disease, we see false positives with that too. We also see the TTG-IgA elevated in other diseases like Crohn's disease, or up to 20% of kids with EoE can have a TTG that's elevated. And so while it's a great screening test, it is not enough to make the diagnosis. And so when we talk about elimination diets, the one diet I really do not want people to come to me on already is gluten elimination. Every single test that I have for celiac disease depends upon gluten being in the diet. And I say this to every pediatrician group I can get in front of: don't eliminate gluten. If the wait time is long and the kid has a positive TTG screen, call me. I will find a way to see them, because I know kids, parents don't want to continue to feed their children something that they feel like is harming them. So avoid the gluten elimination at all costs, because I don't have many tools once the gluten is out of the diet. The other tools at our disposal, so we do have some ability to test for lactose intolerance. There are breath tests that can be done. Kids need to be at least 5 years old. They need to be reliable in terms of blowing into a set of tubes. I'm not a huge fan of the test. Honestly, I think that a clinical story for lactose intolerance is better than the test, which gets all sorts of, false readings. You need to keep a very strict diet before you do it. And if you don't do the diet correctly, then the test is invalid. So, we have that tool available, but it's not something that I tend to use. I much prefer people to try 2 weeks without lactose in their diet. We have, the other tools that I guess are specific to me is, endoscopy. And again, this is used in very specific situations, not when we think it's IBS, but if there's concerns for EoE, which again is kind of its own category of food reactions, then we have the ability to do endoscopy and look for that diagnosis.
Yeah. Perfect. In terms, because we're talking about what's a process, right? I mean, making these diagnoses and coming to see you guys and being referred to see you both is a process. It is, we know, a stressful process for parents. So my next question is for you, Sally. I wonder if you can share a little bit about how you as a dietitian can help support and guide families through this process and preserve, things like dietary diversity and sanity at home and all of these things as, Jackie, Joel are making their diagnoses.
Sure. Good night, everyone, and thank you for having me. Yes, the process is very overwhelming. And I think we have to normalize that fear. Families and kids, and if they have siblings, it can be a very difficult situation. So first of all, just normalizing, building a rapport with families. I find it to be extremely important. If possible, after a diagnosis, I specialize on IBD, but after a diagnosis, if you can reach out to families, ideally in a weekly or bi-weekly basis, just to offer support and also motivation, I think that's very important. The first question when families come to me is what their kid cannot eat. And I shift that focus instead of what they cannot eat to actually what they can eat, because there's a plethora of foods that kids can eat and enjoy. This is a time for growth and develop, is not a time to impose unnecessary food restrictions. So that's extremely important. And the topic of food diversity and the importance of having that varied diet, not only for the kid, but for the whole family. As Joel and Jackie were mentioning, having a diet history, and that's extremely important. One of the biggest parts that a dietitian that specializes on IBD or EOE or in general food allergies is like a detective work, I like to say it, because we do either a 24-hour food recall or a 3-day food diary or a 7-day food diary if possible. And we not only ask the kid and the parents what the kid is eating, but we go a step forward and we ask for food recipes, what recipes was, and thinking that maybe the parents believe that they suspect an egg allergy. And at the end of the visit, the kid would be eating egg, but he's having baked eggs in many food products. So that alone, we are avoiding an unnecessary restriction. So that's how we guide and we support, again, not only the kid, but the family.
Yeah. No, that's great. And I think, thinking of you as an additional partner in this journey, right? Not only to learn from you as, as parents, as primary care pediatricians, specialists, but also to think of you as an additional partner. And we're lucky, to have you here at our medical center. It's the beauty of practicing in this type of setting, right? So I want to move on, and we are going to get to more questions. We're going to save time at the end for additional questions, because I know there's a few more that have come in through the chat. So keep sending them. We'll answer some right now. We'll answer the ones that we don't get to at the end. But I wanted to talk a little bit more as well about the prognosis, right? What can we expect? Because sometimes it's, we make a diagnosis and the next thing the parents will ask, as is, well, but for how long? Is this forever? Is my child going to have a food allergy forever? Is my child going to have a food sensitivity? Is my child going to have celiac disease forever? So how do you handle those conversations? I'll go to you first, Joel. And really, what do we know? What's the latest about the prognosis of some of these conditions?
So yeah, it's actually a pretty exciting time for some of these conditions. And there's a lot of new data that's been coming out recently regarding food allergies, FPIEs, proctocolitis, all of them. And our guidelines have changed, which is very exciting. And it's always nice to be able to share good news. And unfortunately, sometimes you do have to share bad news about certain foods. But that's the thing also, is it depends on the food in question. So with proctocolitis, the likelihood of outgrowing that is extremely high. And we used to say reintroduction of milk by 12 months of age. Then we started to realize that maybe that's, being a little bit too conservative. And we started realizing 8 to 12 months might actually be a better time frame. So now the current recommendation is actually 6 months from last exposure, or 12 months, depending on the age of the child. But anywhere in that 8 to 12 month range, or 6 months from the last exposure, is where I typically recommend beginning to reintroduce milk if that was the culprit food for the proctocolitis, or soy, or whichever the offending agent was. When it comes to FPIEs, we found that 12 to 18 months is the typical time for re-exposure. And while there is no actual test that we can use to make the diagnosis or to follow along, the gold standard for that, as well as for food allergy, for both the diagnosis and diagnostically to prove outgrowing, is a graded oral challenge. So actually having the patient come in, eat the food in question with us under observation, where we can treat if there's a reaction, but obviously, hopefully, we hope that there won't be. And so for FPIEs, 12 to 18 months is the typical age where we see kids beginning to outgrow it, which is exciting. We used to say 2 to 3 years of age. We used to even sometimes wait longer, but now we feel pretty comfortable to say for a patient that even an 8-month-old that presents with FPIEs, to say 12 months from now, let's go ahead, bring him into the office and challenge him. For food allergy, this is where we see the greatest kind of discrepancy, and it depends on the food. Milk and egg, for example, and soy and wheat, these have very high rates of outgrowing within both adolescents, sometimes even to teenage years, but we still see the vast majority of kids outgrowing this, 70 to 80%, sometimes, depending on the food, even higher than that, will outgrow their allergy. And actually the ability to tolerate baked egg or baked milk, so that's egg and milk that's baked into a product such as cake or cookies, is a good prognostic indicator for the ability to outgrow it. And in our clinic, we actually have protocols that we'll start kids on if they're tolerating baked forms of the food, that will actually help them outgrow their food allergy to the direct form or the unbaked form within about 6 months or so. So it's always, great to be able to share that news. Unfortunately, sesame, tree nuts, and peanuts, these foods do not have as high rates of outgrowing, which is why it's so important to get for these to be the first of the allergenic foods to introduce into the diet, because these are the ones that we get very worried about. If an allergy develops, it's much harder to outgrow. And so for peanut, depending on the study, it's no higher than 20%, but it's probably, unfortunately, in most cases, less than 20% will outgrow their allergy. Tree nuts, it's even less. It's closer to 9 to 10%, depending on the study. So peanuts, tree nuts, sesame, these are foods that are very difficult to outgrow an allergy once it sets in.
Yeah, it's so important to do what we can to prevent those allergies in the first place. And Jackie, what about you? How do you talk about some of the conditions you treat?
So the prognosis depends, yes, on the different conditions. So for celiac disease, the prognosis is very good. It does require a strict gluten-free diet. However, if you do that, then the small intestine heals completely as if, they didn't have the disease at all. Similar with EOE, when we find the appropriate food triggers, if the patient is going on a dietary route for treatment, then we get and aim for complete healing. I think the question about prognosis and treatment of IBS is probably the one that's the most wishy-washy, because there's so many factors that play into IBS. And I just want to pause here for 1 second about IBS. I kind of moved over it from diagnosis, but I think when people talk about food sensitivities that don't fall into one of these other categories like food allergy or celiac or EOE, a lot of them end up in this bucket of what we call IBS or irritable bowel syndrome. And we're actually really trying to move away from that term because I think it's been somewhat, discredited and brushed off over the years. And we understand a lot more about the pathology of it now, and we're calling them disorders of the gut-brain interaction. And I think it's a much better term because it has a lot to do with not only the foods that you eat, but your lifestyle, your stress levels, and all of that plays in. And the food part of it has a lot to do not with any particular food, but kind of the classes of food that they're in. So some foods tend to produce a little bit more gas. That gas distends the small intestine. And for people with disorders of the gut-brain interaction, that distension causes a significant amount of pain when in other people it would be completely ignored. And that's kind of the backbone of, classic bloating, diarrhea type IBS or disorders of the gut-brain interaction. And so when it comes to prognosis there, it really depends on lifestyle, right? If we can find a few triggers for patient symptoms and it's easy for them to eliminate, then their prognosis is good and it doesn't interact with their life. But if you have patients who have a lot of foods that cause these symptoms, or if they lead a high stress life that they don't get under control, then the prognosis can be poor and their lives can be significantly affected. The tough thing with this is that we don't have any tests to tell you which foods you are sensitive to in your disorder of the gut-brain interaction in your IBS. There are well-known groups of foods, and again, this is why a super detailed food diary makes a huge help, because there are these food groups that we call the FODMAPs. So it's a mouthful, which is why they have this nickname: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And within these groups, you find foods, and it's not intuitive at all, the list. And you find foods that can cause either this increased distension from gas or increased fluid in the lumen. And in these particular individuals, that causes a lot of discomfort. And we have some medications, but and also some foods. And so the prognosis there is really, very, very variable. And then the last thing I would just touch on is one specific food sensitivity that people come and talk about a lot, which is non-celiac gluten sensitivity. And, there's a lot of research kind of gone into this recently about what is this actual entity and are people really having issues with gluten. And actually more of the recent data is suggesting it's not the gluten protein that's the problem. It's other components of wheat and grain. So there was a really fascinating study where they took a bunch of people who had kind of self-proclaimed non-celiac gluten sensitivity, and they put them on a low FODMAP diet. So again, a low amount of all these foods that tend to cause more bloating and distension and liquid in the gut. And then they randomized them to 3 groups, and they gave one group a high gluten load, like a protein powder of just gluten. They gave another group a low quantity of gluten, and they gave the third group placebo, and then they followed their symptom scores. And the high gluten group had the lowest symptom score. They had virtually no change. Okay. Interestingly, the placebo group, they had the highest rate of change in their symptoms. So it was and that's been done in more than one study, pretty good evidence that it's not the gluten protein that's the problem. From a practical standpoint, I don't know how much that matters, whether or not it's the protein or the fructan in the bread. You're still going to avoid the bread. But, I think we're just trying to move away from some of the nomenclature that's been carried through, because I think a lot of people get dismissed when they say, oh, I have IBS or I have gluten sensitivity. There's something there, and we need to validate that. It's just about how we think about it and how we kind of suss out the details.
Yeah, very, very helpful, even for me as a primary care pediatrician, to try to move away from using the term IBS, right? And even milk protein allergy, right? Joel, could you briefly touch on that? We were talking before we went live that you guys don't like the term milk protein allergy. Tell us really quickly about that.
Of course. Yeah, thank you. So the reason why we don't like the term milk protein allergy, which really commonly refers to food protein-induced allergic procticulitis, is that by the nature of the term, when someone is allergic to milk or to egg or to peanut, they're allergic to the protein that's in the food. So by saying milk protein allergy, we're really saying milk allergy. And procticulitis is not the same thing. It doesn't involve the same pathway and doesn't cause the same symptoms, nor is it treated the same. When it comes to a milk allergy, again, that milk protein allergy, the issue there is it's potentially can lead to a life-threatening condition. It presents with the hives, swelling, coughing, wheezing, shortness of breath, nausea, vomiting, diarrhea, lethargy, hypotension, all the symptoms that are associated with allergic reaction, and needs to be treated with epinephrine and with other supportive care such as antihistamines. When it comes to the proctocolitis, that's simply an elimination diet. However, if there's accidental exposure, it doesn't lead to a life-threatening reaction. The inflammation and the blood in the stool, though it is very striking when one sees it, is still a self-limited condition, still self-limited inflammation of the gut, which will resolve with removal, but not leading to an immediate life-threatening reaction the same way a milk allergy would. So we tried to only use the term milk allergy or milk protein allergy, if one would use that term, to only refer to a type 1 IgE-mediated hypersensitivity reaction, or that true allergy, that food allergy that we're talking about, because of the nature and the severity of an accidental exposure leading to a life-threatening reaction and the immediate need for treatment with epinephrine in such a situation. So we're very careful about using that milk allergy term because we are worried about a life-threatening reaction. So when we say milk protein allergy, really, again, that milk protein is the aspect of the milk allergy. That's the portion that's of milk that someone is allergic to, versus, for example, lactose intolerance, where it's an inability to break down the sugar that's in milk. Here, what one is allergic to when you say a milk allergy is the protein. So really, milk protein allergy and milk allergy are the same term. And again, it's referring to that dangerous, that food allergy that does require immediate treatment, not the proctocolitis, which, though very striking and can be very uncomfortable for the patient, not immediately life-threatening and needs to be treated differently.
Yeah.
And if I could just add, Edith, one thing that just kind of echoes this, it's very confusing for parents. And I think like we can think about it in our kind of medical terms, but if parents are told the kid has a milk protein allergy, they become very afraid to introduce milk when it's appropriate. And I have a lot of patients that come into my office at 1.5 or 2 years of age, and they were told, oh, my baby has milk protein allergy, and they don't reintroduce, or they introduce lactate because they don't understand the difference between, just like Joel was saying, an enzyme deficiency like lactose intolerance and a true, protein reaction. And I stress this for one additional reason, which is that with the rise, and Sally may be able to add to this, with the rise in popularity of the nut beverages and the availability of all these kind of like milk alternatives, which are really not nutritionally great for a 1 to 3 year old. I have patients come into my office with failure to thrive, and it's because they have no calories. They're drinking all this, empty, again, nut beverage, because some of them are afraid of milk, because no one's really explained the difference between lactose intolerance, food protein induced allergic proctocolitis, and milk allergy. So whatever pediatricians can do to kind of like very quickly, it takes 1 minute to just say, this is not lactose intolerance, this is not a milk allergy, your child will likely outgrow this.
Yeah, no, thank you. And it's, it's real life consequences, right, to the terms that we use. So I'm just grateful that you guys are here and giving us this time to help us clarify this and guide families. Sally, on your end, as these things go on for additional years, right? Like one thing is sort of the acute diagnosis, and then this sort of persists. And Jackie mentioned this a little bit, like the families that come in and the kids now have failure to thrive because they've been afraid. How do you continue to partner with those families in time? How do you continue to support, and how can you teach us to continue to support through time?
Yes, a great question. And I want to also echo what Jackie was saying with regard to these plant-based milks. I don't like the word milk for, let's say, almond milk. It's not a milk, it's almond liquid. That's very important. It's oat liquid. It's not a milk. And yes, I have many patients coming, let's say with IBD and saying, oh, I cannot eat because I I went to, I Googled it and it said that they recommend these plant-based milks. And at the end of the day, they're not providing calcium, which is very important. They're not providing enough protein. Okay. And again, diets for kids, they need to grow and develop. And if a kid should be drinking 2 to 3 cups of milk, there's a reason behind it, right? So that's extremely important. And yeah, there's a lot of, let's say, popularity between these liquids, and it's important to educate the patient. And I think knowledge and education is power, and then you can see how the families react by knowing this. So how we can partner and how I, let's say, maintain also this diversity in diet is I explain to parents, we need a lot of nutrients, and the more varied your diet, the more nutrients you, your family, your kid is going to have, and they're going to be able to flourish. Mealtime is extremely important. If you can do it at breakfast, you cannot do it at lunch. Let's try to do it at dinner. I'm not saying every single night. There's like difficult times, and I know it's if you have other kids, it can be overwhelming, but a mealtime should be as stress-free or the less stress possible, because kids are going to learn from you, okay, your behaviors, what foods you eat. It's an excellent time for food exposure, which I see all the time. Families coming to me and saying the kid tried, let's say, carrots, and he didn't like it. And when I ask how many times he had the carrots, once, but he didn't like it. He didn't like it. Okay, let's say he tried it 2 times. Okay, that's not enough. It takes about 20 to 30 exposures, and we can do it during mealtime, and that's extremely important. Many times, don't offer the carrot if you know he might resist, but you can do it in other forms. Even if, let's say, and this is another form that I use just to support the diet diversity, it's cooking with your kids.
Right.
Okay, age appropriate, but even if it's, let's say, going back to the carrot example, if they don't like it, maybe they will have it in a muffin. Maybe they will help you shred the carrots. They will feel proud about themselves and something they make, and that will increase the chance of they actually eating it. Yeah. Something also extremely important, I see this all the time, is parents say the kid tried it, but he didn't like it. He spit the food. That's a step forward. I always tell my families, if you want to go from point A to point C, you have to go through B. B is that kid smelling that food and saying, yuck, this is disgusting. It's fine. And we can just say, listen, we don't use those words. It's not of your taste. It's fine. But thank you so much for trying that food. And eventually the kid will try it, even if it's in other preparations. So that's very important. That's a small victory, which has to be celebrated. Also going to a supermarket. I remember during COVID, I used to give the recommendations and they were not possible. But right now, take your kid. There's so many kids that don't know how a pineapple looks like or where does it come from. Yeah. Maybe they can try, this is true, maybe they can try, they see like a shiny red apple, they want to try, that's great, but take them to the supermarket, see if they want to choose something, and also it's also their choice, better than us telling them what to eat. Something important, also crucial, during mealtime, I see a lot of tension because the parents are pushing, because they want their kids to eat a diverse diet, which granted, but your responsibility as a parent during mealtime, because you have several responsibilities as a parent, but during mealtime is to offer a variety of healthy foods. That's your responsibility. The kid's responsibility is to decide whether they will eat that food and how much. So that takes the stress from the parents pushing, have to eat this, or I'll give you a prize if you do that.
Right.
So let's not do that, because then the kid is going to, kids are very smart and they will know that that food is the one that you want them to eat, and they will start asking for prices and whatnot, instead of really understanding and having what we all want, a healthy relationship with food. And that's what we want. We don't want the kid to start thinking, okay, that's like a prohibited food, or this is the food that is better, quote unquote, than the other. We don't want that. And that will help not only the kid when he's 5 or 6, but when he's a teenager and during his whole life.
Yeah, no, absolutely. And all of these things are so important for every child, right? And you know, feeding your child can be such a source of stress, although it also can be really fun, but it's even more important for kids who have developed a food allergy or food sensitivity or celiac disease, right? So keeping those like basic strategies in mind is so important. Joel, I want to transition back to you and ask you a little bit about exposure therapy. So when it comes to food allergies, when are they indicated? What types of allergens do you do them for? And who are the kids we should be thinking of to send to you?
So when thinking about food allergy and exposure therapies, typically the one that everyone's referring to in kind of the buzzword now is the oral immunotherapy, or OIT.
Right.
And this is effectively desensitization to a food. So giving small amounts of the food built up over time to a desired target dose, and then maintaining them on that dose. Now, it is effective. It's becoming much more common to be commonly used, but there are some drawbacks to it. For example, desensitization does not cure an allergy. It only allows exposure to that allergen. So for example, if I desensitize somebody to peanut, to let's say 3 grams of peanut protein, that means that they will be ingesting 3 grams of peanut protein a day. And if there's an accidental exposure to peanut, hopefully they won't react because they've already had this level of exposure to peanut. But let's just say we desensitize them and then they stopped eating that peanut daily, and 6 months go by and they want to restart. There is the potential that they will have resensitized themselves to peanut and could have a reaction with that re-exposure. So it doesn't treat, it only allows, while that food is in the system, for you to continuously eat. So that is one aspect that I always need to counsel patients, that we're not curing, we're just allowing for tolerance. Now, right now, there are some very interesting studies coming out that shows that if we start the desensitization process early enough, so if we're talking infants, 7, 8, 9 months of age, very young kids, and we do this over time, by age 5, some of them actually do develop some degree of tolerance. And so it may help them outgrow, but the studies are still pending on that, the large studies. So there's some good data to suggest it's helpful, but we're still not there yet in order to say every kid should undergo this. There's the other aspect of this process, tends to be very labor intensive. So I always warn families, it's going to be a lot of appointments coming in. And unlike when you simply avoid a food, and in theory, there's very little risk of reaction because you're not exposing them to the food. Here, we're actively giving their child something that they're allergic to. So the risk for reactions goes up dramatically. And so families do have to be aware and counsel that there is a high likelihood that there's going to be a reaction at some point in time, and they have to feel comfortable with that. And then another big warning I always give families when considering this is there are a lot of lifestyle modifications that come with it. For example, things that we take for granted, like the ability to do a hot shower at night, or to exercise, do sports and things like that. Well, for 2 hours after your dose of the food, you actually can't do hot showers. There's no exercise or strenuous activity. So these things have to be taken into account when making the recommendation. Are families okay with that? So everyone should be evaluated, because you can do it for any food. There are protocols written for almost every food at this point in time. There are a few centers that do multiple foods, because if there's ever a reaction, you're not sure which food it is that triggered it. So most centers that are doing OIT, or that oral immunotherapy, are doing it to one specific food or one food at a time. But families do need to be warned that of all these aspects. So everyone should be evaluated. I think it's a great thing. It's a great tool, especially when used appropriately for the right patient at the right age. But families also do need to go through a lot of counseling, make sure that they're ready for it, and this is something that's appropriate for them. So it's really decided on a case-by-case basis. Every case is unique, every family is unique. And what we like to do is, have that referral, send those to those patients. We'll talk to them, we'll counsel them, we'll find out if this is right for them. And if it is, we'll get started. If it's not, we'll let them know that as well. But every patient should be evaluated for it. And then once we know, once we've counseled them, it's a decision on a case-by-case basis. So that's where shared decision-making is so critical. Families have their input. We provide our recommendations, and we come to a mutual understanding and agreement.
Yeah. Super helpful. We are running a little short on time. Please send us your questions to make sure that we get to them. I also have to ask you a question, Joel, that there's still a lot of debate among us primary care pediatricians. So we know that there's pretty good data that early introduction of food allergens reduces the risk of developing an allergy in the future. The data is probably strongest for peanut, for eggs, but it's starting to get there. And I think we sort of make the extrapolation, and a lot of us are recommending early introduction of allergens, right? There is also a lot of people who are saying still, wait 3 days between introducing one food and another. I do not. I actually do not. My take is that if you are doing that, you're probably decreasing diversity and you're stressing parents out. Because if you're waiting 3 days between every food, it takes you a while to build up your dietary diversity, and you're probably stressing parents out. But what's the official recommendation, Joel, here? What should primary care pediatricians be doing? Should we be saying wait 3 days? Should we be saying go for it, just avoid honey? What's your take?
That's a great question. And so that is actually going to be dependent on which foods we're referring to. Where the 3-day concept comes from is basically exposing to a food. If there's going to be a reaction, you know which food it was that triggered that.
Right.
Is there a place for that recommendation? Yes. Do I do that for every food? Absolutely not. Typically, I'll say introduce one new allergenic, higher allergenic food at a time, 2 to 3 days apart. And then once a food's introduced, make it as a regular part of the diet 2 to 3 times a week to promote that tolerance. So once a food is introduced, we do need to make sure it stays as a regular part of the diet, or you can develop food allergies to it. But which foods actually need that recommendation? That's the key. So which are the high allergenic foods? Peanuts, tree nuts, seafood, fin fish, like cod, tilapia, salmon, and shellfish, really shrimp, crab, and lobster, sesame, soy, wheat, milk, eggs. So these 8 foods are really the primary allergenic foods when we think about them. And these are the foods that I usually will say, maybe do one at a time, 2 to 3 days apart, because we want to be careful when you're using the higher allergenic foods. But after that, vegetables, fruits, chicken, things like that, I don't usually, stand on that 3 days apart, has to be, and then,
the potatoes, the pears, the apples, like those things we do
no
not
need.
eat for 3 days and wait, right?
No need. Let the kids eat. Let it be an enjoyable experience. Like you said, food should be an enjoyable experience. It should be a very bonding experience with your kids. It shouldn't be a stressful environment, or your kids will pick up on that and they're going to get nervous and just naturally start having aversion to a food. So no, you want it to be an enjoyable experience. So by all means, I only say the 2-3 days apart for the higher allergenic foods. Other foods, let them eat. And again, once a food's introduced, you can combine it with a new food as well. So you don't have to be, partition it off. But yeah, let them eat, I always say.
Perfect. We are so sadly out of time, so we're going to have to gather the questions from the Q&A, and maybe we'll send it with additional resources. We are so grateful to our panelists, Dr. Joel Brooks, Dr. Jackie Jossen, Sally Dorfin, who's a pediatric dietitian, for joining us this evening. We will send the link to this webinar after it ends at 7. We will also be sending additional resources. Please sign up for our CME this December. The link was in the chat. We will also send it as a follow-up. And take a listen to our podcast, The Stuff That Matters for Kids Health, and follow us on social media. Again, apologies if we didn't get to your question. We will send a recap and can send some additional answers and resources. And thank you to our panelists and to everyone who joined us this evening. Thank you so much.